Hello, welcome to the Helen Bader Foundation CBRF Caregiver Training Program. This unit is on the management and administration of medications in the CBRF. We've divided the unit into a number of parts, each with a video and a workbook because there's so much information to cover. This is part 4. It's about medications and the elderly. We know how important it is for you to have a basic understanding of medications and how they work in your elderly residents. I'm pharmacist Maren Meyer, and I'm interested in medication safety in the CBRF. We start each of our parts of this unit with a pretest. The pretest and the post-test are identical. There's no grading involved, except that it allows you to identify information that you already know, information that you think you know, and it shows you what kind of information we want you to get out of this particular unit. So, what I'd like for you to do is stop the video now, complete the pretest, and then come back. Welcome back. Now in each unit, feel free to take notes in your workbook and stop the video, rewind if you've missed some information, or stop if you just feel that you're not really paying attention or really getting anything out of the material. Come back when you're really ready to concentrate and to get all the information that you need from these units. The units are not just designed for certification, they're designed to help you become a better caregiver. In this part, part 4, we're going to cover some interesting facts about drugs in the elderly, and then we'll talk about the major drug categories that are used in elderly people. This is a fairly lengthy segment. After that, we will discuss some of the symptoms or side effects that may or may not be related to particular drugs, and we'll talk about some symptoms that could indicate a very serious reaction to a medication. We'll discuss symptoms that are related to specific drug categories that are particularly needing to be monitored, for example, anticoagulants. And then we'll wrap up with some helpful hints to you, the caregiver, on caring for your residents who take these medications. I want to remind you of a couple of things. In each of these parts of this unit, I use the words medicine, medication, and drug interchangeably, so don't be surprised about that. The other thing is I keep a set of notes, and that's because I have a tendency to wander off if I don't have my notes to refer to. I also want to remind you that reviewing is really essential here. Before you come into a new unit, be sure that you've reviewed all the material from the previous unit. That'll be very helpful because reading and hearing information the first time may make you aware of it or may make you learn some new information, but we want you to understand the information and be able to incorporate it into the things that you do every day with your residents. So be sure to get into the habit of reviewing. Well, let's go into the interesting facts about medications in the elderly. First of all, the elderly are more likely to consume medications than any other group of people in the United States. Part of that is because they are subject to having more conditions that are treatable by medications than any other population. They consume about 1/3 of all prescription and non-prescription drugs. In the United States, on the average, the nursing home resident has 8 medications, 5 of which are scheduled medications, and 3 of which are PRN, or for as-needed use. Under A, we've got a list of the categories or groups of drugs that are most commonly used in elderly patients, and that's what we'll be going into in the next section. It's important to realize how much a drug or a medication can affect the activities of daily living in a person, and particularly an older person. Sometimes when an individual is doing fine on one medication, we may have to add another medication for another condition, or to more adequately treat a condition, and the two medications together can really impair a person's ability to feel well or to function well. As you're probably aware by now, drugs and medications act differently in the elderly than they do in the average adult. It's important for you to know your resources, to look up information when you're not sure, and to keep in mind that when a resident is having trouble, it could be related to medications. As you recall from the last part of the previous part in this unit, the absorption, distribution, metabolism, and excretion of medications is changed significantly as you age. As we go through this part of the unit, I'll be mentioning just part of the information that's included in your workbook or your handbook. Be sure to read the entire workbook. It's important that you get not just the information that I'm offering, but also the information that's in your workbook. And when you see something that particularly interests you, go to your drug reference and look that drug up and find out more about it. Let's start now on the major drug groups that are used in treating elderly people. Before we get started, I want to explain how I'm going to approach each of these sections. First, I'll offer you an example of some of the drugs that we find in that group. Then, I'm going to talk about the changes, significant, major changes that occur in absorption, distribution, metabolism, and excretion of the drugs. Because this is such a lot of verbiage to say, I'll just refer to these as A, D, M, and E. Just because I may not mention a major change in those systems doesn't mean something doesn't occur. So if you're suspicious of something, be sure to look the drug up at your drug reference or check with one of your resource people. After we talk about changes in A, D, M, E, I'll mention some of the main effects and actions of the drugs in that group. And then we'll wrap up with a few of the helpful hints that are included at the bottom of each page that are for caregivers caring for individuals who have conditions that are treated by drugs in that category. So let's get started. The first of the groups is analgesics. Two examples are codeine and aspirin. Now, as far as the ADME changes in elderly people who take analgesics, the absorption is slower and more variable, and it's important to give these drugs, particularly acidic drugs like aspirin, with significant amounts of fluid so that they don't ulcerate the esophagus. And this is referring back to information that we discussed in a previous part of this unit. Distribution of these drugs can vary greatly, and if you are concerned that your resident is experiencing some symptom that could be drug-related, you might want to look it up if they're on an analgesic. As I said here, the M and E are not major concerns as far as the elderly. Analgesic effects and actions. It's important to realize that taking an analgesic may often increase an individual's risk for falls, for developing confusion, agitation, and drowsiness. Some of the medications, particularly the narcotics, can cause constipation. Under D, you'll see some important things to remember as a caregiver. Be sure to read through these because I'm only going to mention a few of them. For example, the elderly are particularly susceptible to conditions that cause pain and discomfort. Just because they have pain, don't assume that pain is normal. Pain is not a normal condition for any age group. Prescription drugs, especially analgesics, should be started at the lowest effective dose, but they should be given at an effective dose, not just an almost effective dose. And generally speaking, and this goes for most drugs, the shortest acting drugs are usually the safest in the elderly. Let's go on to the next category. That's antacids. Now, the antacids are mineral ions in general, but also antacids now we can include drugs like Pepsid and Zantac because they do decrease acid production. But normally when we think of antacids, we think of things like Maalox, Mylanta, Tums. And as far as the ADME changes in the elderly, we don't really expect these drugs to be absorbed, so we wouldn't expect to have any changes there. If the drugs are absorbed, we do sometimes see some problems with excretion, though. Normally, antacids are used, they act in the intestines, and their main purpose is to neutralize stomach acid that may be causing either stomach distress or a reflux from a hiatal hernia. Some of the antacids can cause diarrhea or constipation, and often you'll see an individual who will be alternating an aluminum salt like Amphogel with Maalox, which has magnesium in it, and that sort of balances the constipating and diarrheal effect of the two drugs. It's important to remember that antacids, unless the physician has ordered them, antacids are only to be used as periodic or occasional drugs. They're only for occasional relief. Prolonged use of the antacids may cause them to be absorbed and can cause some kidney problems then. It's also important to remember that antacids have a tendency to interact with a lot of medications. So before you administer them, be sure that you've looked up the information in your drug reference, which I hope you're referring to a lot these days, and make sure that they shouldn't be given, say, an hour before or 2 hours after other medications. Remember that even though a lot of these drugs like Tagamet, Zantac, and others are marketed without a prescription, they are still drugs. And Tagamet, for example, in particular, has a tendency to interact with a lot of the other medications that elderly people take. Group 3, anti-anxiety drugs. Some examples here are lorazepam and alprazolam. The ADME changes that we see in elderly people, first of all, the absorption can be erratic. The same amount will probably be absorbed, but it may be absorbed more or less rapidly, depending on the individual. The distribution varies. Now, it's very important to remember that these drugs get distributed into the brain, and they have a tendency to be distributed more thoroughly into the brain of older people than of younger adults, which means that a smaller dose may be more effective or even may cause some adverse effects in older people that you would see in someone younger. The metabolism is less effective, so we do sometimes see a buildup from these drugs. Some of the drugs have a tendency to build up more than others, and I've listed for you some of the drugs that I think are a little bit safer in this category. Excretion is not a major problem with these drugs. Now, the actions and effects of these drugs in the elderly, I guess there have been considerable number of studies that show that adding an anti-anxiety drug to the drug regimen of an older person can significantly increase their risk for falls. It may even be 100% increase. That's normally for the first 2 weeks after initiating or changing a dose. It does affect balance, but if an individual has a medical condition of anxiety, these are perfectly appropriate drugs to use. Anti-anxiety drugs are categorized as psychotropic medications, and as such, you can't have an order for just a PRN or as-needed medication unless the resident is on a scheduled dose of that medication. So that's an important thing to check. If you recall back in part 1 of this unit, we included the medication-related parts of HSS 83. So you might want to go and review that information. Under the important things to remember when administering anti-anxiety drugs to elderly people, It is important that you provide other supportive techniques or therapies to individuals when they're suffering from anxiety. A lot of older people have many reasons to be anxious. They have a great number of losses in their lives. They have a number of troubling changes that are occurring. But when the drug is ordered, be sure to administer it without making an individual feel guilty about taking it. The effects of these drugs may not really be seen for several days or even weeks after they've begun to be administered. So you have to kind of support the individual while the medication is becoming effective. Let's move on to anti-infectives. Some of the examples under anti-infectives include penicillin or amoxicillin, erythromycin, which, as you recall, is one of the drugs that interacts with very many other drugs, and sulfonamides, like Bactrim or Septra. Looking at the ADME changes in elderly people taking anti-infectives, absorption can be sort of erratic, and that may be related to the change in acidity in the stomach of older people. Most of the distribution and metabolism are not major concerns, except with the case of some of the erythromycin derivative drugs. And excretion can be a problem depending on the type of drug and where it builds up. And an example is the quinolones. Floxin and ciprofloxacin are two drugs that have a tendency to build up in the kidney and can cause some serious toxicity if the doses are not decreased and spaced farther apart. Some of their actions and effects, well, as elderly people have a lot more infections, they are exposed more frequently to antibiotics. And so we do see adverse effects occurring more frequently in them. Indeed, under the important things to remember when administering medications of this type to older people, you need to remember that there is a greater chance for these people to have or develop allergic reactions. So what may seem safe today, or what the antibiotic that was perfectly okay 3 weeks ago, may no longer be safe. So you can't really make any assumptions about that. It's important that these drugs be given for an adequate amount of time so that the condition is treated completely. You should never discontinue an antibiotic or not finish the antibiotic unless the prescriber has directed that. Let's go now to number 5, anticoagulants. The main drug in this category is warfarin. Anytime one of your residents begins warfarin, you need to go back to your drug reference and review the information about it. You want to compare the drugs that the resident is already taking with the lists of drugs that are affected by warfarin. Anytime a drug is added to that person's medication regimen after they're on warfarin, you need to review those lists again. This is a drug that interacts with almost everything, including foods, as you recall from a previous part of this unit. If you look at the ADME changes, you can see that in older people, it can be all across the board. So you can't make any assumptions here. This is just a very dangerous drug that is therapeutically a very good drug, but requires very cautious monitoring. And that would be a good thing for you to keep track of in your progress notes in the resident's chart. Now, the anticoagulant effects and actions in older people, as I mentioned, it changes everything. And it does reduce the blood's ability to clot. And that is its main purpose, to keep people from having clots that could cause strokes or pulmonary emboli or clots in the leg that would impair the circulation to the legs. Important things to remember, we use them much more cautiously in older people, although they are called for in many older people. We also have to watch older women more carefully. For some reason, they are more susceptible. The other thing is that's sort of interesting is that people who have been on anticoagulant therapy for a long period of time are more prone to having spontaneous fractures and also developing osteoporosis. So a lot of your residents who are not already being treated for osteoporosis just with nominal daily amounts of calcium, you might want to check with the physicians about that. It's a preventative measure and can keep your residents a lot more comfortable. Now, one other thing before we go on, and that is the use of aspirin. Many residents take 1 aspirin a day or an aspirin every 3 days or baby aspirin daily. It's okay to continue that. Normally, you wouldn't want to treat pain with aspirin in patients who are taking warfarin. You want to only use aspirin as directed by the physician when an individual is taking warfarin. Let's go on to number 6, the anticonvulsants. Some examples here are phenytoin or Dilantin and carbamazepine or Tegretol. The ADME changes are significant in this category. The absorption can be slower and variable, especially when brands are changed. And what I would suggest here, I've thought a lot about this, is ask your pharmacist not to change brands, even generic brands that are approved for your elderly residents once they've been stabilized on a particular medication. The variability may just be enough to cause the older individual a problem. So have them put on the patient's profile that they will not change brands and that they will use a particular manufacturer's brand of a generic or the particular brand product. The distribution varies a lot. As you recall, these are bound to plasma proteins, so they compete with a lot of other drugs. Metabolism is going to vary, but excretion, fortunately, is not a major problem. Some of the effects of anticonvulsants are that particularly things like valproic acid or Depakote can cause some abdominal pain, and you need to keep track of that in your progress notes. That may be something that's not a problem, but it also may indicate a liver problem if it's prolonged or becomes severe. These drugs interact with everything, pretty much, and they do have the possibility of causing some obnoxious side effects, which include, for example, the inability to keep your eyes focused on a page. So if you have an individual who really enjoys reading, these can be somewhat disabling products. They are necessary to prevent seizures, but make sure your residents feel comfortable in telling you about any problems they may be having with these medications. Important things to remember. Well, we talked about where seizures come from in older people. Very often they're related to falls or the occurrence of a stroke. The blood levels of these drugs do need to be measured routinely, and you should have a file that reminds you that the resident's going to have those blood tests. And the anticonvulsants can affect the blood levels of other drugs either by increasing them or by decreasing them. Number 7 is the antidepressants. Some of the examples here are Zoloft or sertraline and amitriptyline or Elavil. Now that runs the whole gamut of the very newest to the very oldest antidepressants. The ADME changes in elderly basically are not a big concern, but you do need to remember that just the nature of these products causes them to build up in the body. They have a very long duration in the body, and it makes it easier if the individual has missed a dose, but on the other hand, when the dosage is changed, a lot of patience is required to wait to see what kind of effect that dosage change will have. So normally it's not a good idea to see the antidepressant dosage changed several times in a week, for example, because you really haven't had time to see the full effect of the dosage change. Some of the actions and effects in drugs like amitriptyline or the heterocyclic antidepressants, you'll see this group of side effects which we call the anticholinergic side effects. And that includes constipation, blurred vision, urinary retention, dry mouth, and drowsiness. Normally, we don't see that with the group of drugs that includes the Zoloft type of drugs. Those drugs may cause some alertness or drowsiness, and they more often cause a little nausea, maybe some mild diarrhea or headaches. Normally, the older products, the ones that cause the anticholinergic side effects, are going to be given at bedtime, and that's because of the drowsiness. These drugs can alter blood pressure, and so when a person changes their posture, say they go from sitting to standing or from lying to sitting, they may become lightheaded, and of course we have to worry about the risk for falls there. Some important things to remember: as we mentioned in a previous part of this unit, the incidence of depression increases as an individual ages. And this is not just not pulling yourself up by the bootstraps. It's actually a biochemical change, and these are usually pretty effective methods for treating this condition. Antidepressants tend to be more effective in the newly depressed individual as opposed to individuals who have had repeated depressions. They are not addictive. That's very important to keep in mind. The other thing is that they don't usually, unless an individual has a condition called manic depression or bipolar disorder, they don't elevate the mood beyond normal. They just bring the mood back up to normal. So it's not an exaggerated effect. Normally, in an individual who has their first episode of a major depression, we recommend at least 6 months of therapy. Often individuals may need to remain on antidepressants indefinitely. And fortunately, they are not addictive, so that is not a problem. Under no circumstances should these drugs be suddenly discontinued. Well, unless the individual has some kind of a catastrophic reaction to the drug, because the side effects of sudden discontinuation can be very unpleasant. Let's move on to the anti-diabetic drugs. That's in number 8. Examples there are Oronase or tolbutamide, which is one of the older products, glyburide, which is diabeta, and I think micronase also, and then the injectable antidiabetics, which include isophane, insulin, which is Humulin N. The ADME of these particular agents is not particularly of concern, although as always, if you suspect a problem, you want to be sure to go back and look up. Because when I say not a major concern, it may be a concern in 1 out of 10,000 people, but that does leave that one person out of the 10,000 that could have a problem. The older agents remain in the body longer, and so we've gradually gotten many of our diabetics away from those agents. In addition, the older agents like chlorpropamide or diabinase and tolbutamide, my example here, interact with alcohol and can cause a very unpleasant syndrome. So even though alcohol is not a good product for diabetics to consume, it is particularly bad for individuals who are on those kinds of anti-diabetic medicines. And you should remember here, look up the medications because a lot of drug interactions are possible. Some things for you to remember. You want to really post. Later in this part, in this workbook, you'll find a list of the signs and symptoms of both low, which is hypo, and high, which is hyper, blood sugar, which is hypoglycemia and hyperglycemia. It's important to have those posted in your facility, and you want to learn those. So if you want to take on another task right away and become more knowledgeable, that would be one of the good places to start. Know those signs if you have diabetic residents in your facility. The classic signs, however, may be absent in older people. And so the first thing that you may see when an individual has low blood sugar is they may act confused or agitated. Anytime that happens in an elderly resident, you always want to search through the possible medical conditions that could be causing the confusion. In number 4, we have a list of some of the items that you might want to have on hand, like orange juice or hard candy. Those things are only effective as long as the individual is conscious. Once the individual is not conscious, you do have a medical emergency, and those products should not be given because they might cause the individual to choke. Group 9 is the antihypertensives. And some examples there are metoprolol or Lopressor, Procardia, which is nifedipine, and Capitan, which is Captopril. The ADME, which is, you remember, is absorption, distribution, metabolism, and excretion. The changes with these drugs may or may not be a problem. There are so many different types of drugs in this category that initially you'll probably need to look some of these things up. One of the problems with excretion of antihypertensive drugs is that these drugs are often intended to act in the kidney to alter its actual function to bring the blood pressure down. And so you're altering the excretion to improve the condition. And it's just something to keep in mind. These drugs act by either by changing the diameter, the size, and capacity of the blood vessels, or they may slow the rate of heartbeat. They may change the salt balance and fluid balance in the kidney, like Captopril does. And you need to recall that anytime that you adjust blood pressure in an older individual, they have less of an ability to adjust to a change in position. And so changing position does increase their risk for falls. Some of the important things to remember are, whenever possible, you want to accompany drug therapy with the appropriate diet, exercise, and weight reduction. Now, that's so easy to say, but it's so rarely done. It is important to try to reinforce this with your residents and with yourself if you are taking antihypertensive medications. There are a lot of non-drug measures that will work for people who can move around and get a little mild exercise. And have the resident's physician recommend what kind of gradual changes an individual can make to their lifestyle. It's very difficult to make lifestyle changes, and it's often easier just to add medications. But in the elderly, adding medications presents an additional risk. You want to learn how to evaluate blood pressure, both standing and sitting and lying. And if an individual complains of lightheadedness, then you should be measuring that blood pressure as the individual changes position. And that's something you can ask your resident nurse about. Let's go to number 10, the anti-inflammatory drugs. Examples here are naproxen. Now, naproxen is available both as a non-prescription or OTC drug, as Aleve, and as a prescription medication under various brand names. Another anti-inflammatory drug, which is a steroid, is prednisone or deltasone. Others include things like ibuprofen and ketoprofen. Normally, the absorption of these drugs is a little slower. Distribution and metabolism are not major concerns. Excretion can be a big problem, particularly with the drugs like naproxen, which do alter the function of the kidney. And you may have individuals who experience some edema. They may have high blood pressure from the medications. The other thing to remember with these drugs is that they can cause bleeding, very serious bleeding, without any symptoms that announce it. Just suddenly the individual may develop a bleed. And what you're looking for is tarry stools, low blood pressure, pale skin, and a feeling of malaise or just feeling bad. You want to be sure that you do monitor those things in your progress notes. When an individual has been on steroids for a prolonged period of time, it's important to know that their body is not creating its own steroids. So that drug should never be discontinued without a very, very gradual taper. And that has to be done over a long period of time carefully by the patient's physician. A resident refusing a dose of prednisone when they've been on, for example, 10 milligrams a day is something that you would need to contact the physician about, because it really would adversely affect your resident. Other things to remember: give these drugs with a glass of milk or with some food to help buffer the effects on the stomach itself. And keep in mind that some of them may make asthma worse, just like aspirin can. These drugs, because they have the ability to decrease fever and to help with analgesia or pain relief, can mask some serious conditions, for example, infections or, say, a fracture even. Number 11 is the antipsychotic category. And the examples we have here are Haldol and Risperidol. Anytime one of your residents is put on an antipsychotic medication, look up that particular drug and look at the function that your resident has prior to starting that medication. The A, D, M, and E of this drug category can vary considerably from one individual to another. One of the intentions of these drugs, or one of the major effects, is that they decrease motivation and initiative. And those are some things that normally in our society we value. So remember that by treating an individual with these medications, you're taking away something of social value to them. We try not to use these medications unless they are truly appropriate. Another reason for that is that about 20% of older people will experience some kind of muscle rigidity or motion disorder that's similar to Parkinson's disease, twitching, stiffness, and sometimes those conditions are not reversible. So certainly we monitor very closely for that. And I'm sure that you've been exposed now to some of the forms that are used like the AIMS form that's used in monitoring motion disorder changes. They take a long time to act before they are truly effective for challenging behaviors. Their first effect is usually drowsiness, but it may take weeks for them to have an antipsychotic effect. In the interim, what you have to do is deal with all of the unpredictable things. They may make confusion worse. They may cause these motion disorders. They may make the individual not want to come out of their room or get dressed or participate in activities. So there are going to be a lot of possible things to contend with when using antipsychotic drugs. Under D, important things to remember when treating elderly people with antipsychotic drugs. Normally we use these to treat manic depression, schizophrenia, and severe agitation. The risk for injury is particularly high in elderly people who take these medications because of low blood pressure and the sedation that can occur. They do have very unpredictable effects. Let's move on to 12, digitalis preparations. This group is exemplified by Lanoxin, which is digoxin. That's really the only current used drug in the group. The ADME changes are that absorption is very erratic. It may be decreased. Normally, lower doses are prescribed in elderly people because of the distribution of the drug. And the drug tends to build up in the body. It relies on kidney excretion. And with the poor kidney function of older people, we find that much less drug is required, and that even when we discontinue this drug, it remains in the body for a very long period of time, a month or more. Some of the actions and effects of digitalis in the elderly, as you recall from one of the previous parts of this unit, it strengthens the heart muscle, so it causes the heart to contract more strongly and pump out more blood, but it does that at the expense of the heart rate. It slows the heart rate. When the dosage of digoxin or lanoxin is altered, you need to wait to see what kind of effects occur. It's important to monitor for signs and symptoms of toxicity from digoxin, and we have listed some of those here. They're kind of vague symptoms, but when an individual takes lanoxin, you need to be aware of changes in their appetite, whether or not they seem just fatigued or slowed down, if they have visual changes, if their color perception is different, if they seem depressed or confused, then digoxin may be part of or all of the cause. Some of the important things to remember when administering these drugs is that while the drug is used both for congestive heart failure and for rhythm disorders, it can cause rhythm disorders itself. So if an individual says they have a strange feeling in their chest, you probably need to check with their physician. Residents on digitalis or lanoxin need to have blood levels checked routinely. And that includes not just the digoxin levels, which are normally checked every, say, 6 months, but they should also be having their electrolytes, for example, potassium checked, because all of these things come into play when you're changing the action of the heart muscle. The resident does need to receive an adequate supply of potassium, and we've listed some information here about that. But be sure you never make these kind of adjustments without consulting the physician first. For example, never put an individual on a salt substitute without the physician's approval, because you could make things much worse rather than improving the things. Category 13 is the diuretics, and some examples there are furosemide and spironolactone. Normally you won't see a lot of changes in the ADME, but one of the reasons I included spironolactone here is that it does require metabolism in order to become an active drug. And if you have liver problems or if you have competition for sites for metabolism in the liver, then the drug may build up and cause some toxicity. These drugs are used for blood pressure, they're used for edema, and they're also used for congestive heart failure. What they do is they alter the water and salt balance in the body, and they do that often by adjusting the kidney function. So you can run into some problems when you give these with other drugs that require kidney excretion. One thing to note is that as people's kidney function fails, hydrochlorothiazide may become a less effective drug for them. Other things that I'd like for you to remember are that even though these drugs do cause an excretion of fluid, it is important that your resident be kept well hydrated. Let the drug and the body take care of the adjustment of the fluids. Don't deprive the individual of fluids. They do reduce the heart's work, and normally we administer these drugs in the morning because, as you know, they cause urination. Group 14 include the laxatives. We've talked a lot about the laxatives already in some of the other parts. But just as a reminder, we have Metamucil, milk of magnesia, and we have the irritant laxatives like bisacodyl. The ADME is not particularly an issue here because we hope that these products are not absorbed. We want them to act directly in the intestines. Their effects are to cause laxation, and they do that by a number of means, but the most important thing is that they require fluid. They require that your resident is adequately hydrated. And you do need to remember that the daily use of irritant laxatives essentially causes a kind of dependence on those laxatives. Some individuals may have already come to you dependent. If they have not, we want to try to avoid making them dependent on irritant laxatives. Under D, we've listed some of the important things for you to remember as a caregiver of individuals who take these drugs. And we have listed some of the causes of constipation, which you're familiar with: decreased activity, decreased food intake, and medications that cause constipation. We also listed some of the common means by which we can help people prevent developing constipation. So be sure to read through that information. Category 15 are the nitrates. A key example here is nitroglycerin. Another example is ISMO. The ADME, basically these drugs do have extensive metabolism in the liver, but normally that is not a big problem, even for elderly patients. The nitrates open up the blood vessels and they allow more blood to flow through. Normally they act on the coronary arteries. Those are the arteries that supply the heart itself. So that's very important. They do have some action on the blood vessels in the rest of the body, so they do affect blood pressure, and they can cause that change of position hypotension as a problem. If the individual's blood pressure becomes too low, or if their pulse increases too significantly, then you do need to contact the patient's physician. Under D, some of the important things to remember when administering nitrates to individuals in your CBRF. First of all, because we normally use nitrates to treat chest pain, you want the individual to sit down. They may even need to lie down. And if you're using the sublingual or the under-the-tongue dosage form, remember that you wait, say, 5 minutes between doses. But if you've administered 3 doses of the medication and the pain has not resolved, you either need to call for emergency help or call the patient's physician right away. That is a medical emergency. The other thing is storage of these products. These are very volatile products. You want to make sure that the sublingual tablets are always stored in the original bottle with the cap tightly closed. The topical preparations need to be stored in a cool, dry place. And anytime you work with nitrates, you want to be sure to wash your hands after touching the medication or the patches, because they can cause your own blood vessels to dilate also and can cause an unpleasant headache. Number 16 is the group that includes the sedative hypnotics, and our example is temazepam or Restoril. The ADME may vary considerably depending on the drug and on the physical condition of your resident. Sedatives and hypnotics are intended for short-term use. They're not intended to be used forever and ever. Normally, elderly people's sleep pattern is a lot different than it was when they were younger, and this is something that you can help them learn to adjust to. And we did cover this information in some of the other parts of this unit, so you may want to review that information. If the medication is causing grogginess in the morning, there are 2 things that you can do. One is you can move the medication to an earlier time in the evening so that it's administered earlier and wears off sooner. If that is not effective, you may need to ask that the physician reduce the dosage. Remember that anytime an individual has taken a sedative and then gets up in the night, for example, to go to the bathroom, they do have a very high risk of falls, and they should be advised to turn on a light to help them navigate when they're up in the evening. Under D, important things to remember when using sedatives in the elderly. You need to remember that these sedatives, while being used to treat insomnia, can cause both nightmares and confusion in elderly people. And they are only intended to be used short term. They shouldn't be used with alcohol. Alcohol disturbs the normal sleep pattern. And barbiturates are almost never used now, and especially not in elderly people, because barbiturates require extensive liver metabolism and can be very dangerous drugs in older people. Try to use alternatives to help people sleep. Have a relaxing conversation with them, even rubbing their hands or their back, or offering just a little solace or some warm milk may be just as effective and a lot safer than using drugs to induce sleep. And be sure to observe your residents for the potential for falls. Under C, you see some symptoms or side effects that could indicate a serious condition that might be related to medications. Some of the side effects that medications can cause can be very serious and would be manifested by some of the things that you see in this list. Become familiar with the list. Things like abdominal pain or jaundice are bad signs under any circumstances, and you need to notify the physician. Under D, there are signs and symptoms of bleeding or toxicity from anticoagulants. This is another good list to post and become very familiar with. Any bruising, signs of bleeding that would, say, include black tarry stools, or any emesis or vomiting that has black content, requires you to call a physician immediately. And be sure that you're getting those monthly lab tests on the anticoagulant medications. Under E, we've included the list that I think you should post in your CBRF. You can post this list or another similar list if you have one that you like better. And it has the signs and symptoms of the high and low blood sugars for diabetics. In F, there's an incredibly long list of symptoms or possible side effects that are related to medications that affect the brain. And we've specified which medications those tend to be: the narcotics, the anticonvulsants, even anti-inflammatory drugs, some anti-infective drugs, some drugs that are given for the cardiovascular system. Be sure to look through these and realize that any time a person's behavior or physical or mental condition changes significantly, it could be related to medications. And if you've been keeping good notes in your progress notes in the resident chart, you'll be able to tell pretty much where the change began. Keep in mind that many of these problems are going to increase the risk for falls in your residence. And falls, as you know, are just so dangerous that I keep harping on them. Remember, the aim of drug therapy is to successfully treat a condition, not to disable a resident or to inconvenience the resident or to make the resident's life worse, and that there are normally alternatives to medications that are being used that may be causing problems. In G, we have a list of things that actually I started using this list in a nursing home to help the nurses there do their charting. And since then, a number of CBRFs have taken up the use of this list. What you do is you first establish a baseline. What is your resident like today? And then each time that you go to chart on that resident's condition, you look at this list and it gives you an idea of things that might have changed that you would want to note and be aware of. These are things that may or may not be related to medications, but are certainly things that you want to keep track of. I want to thank you for joining me.